Hi everyone, let's continue our discussion of the important topics for FMGE. But before that, all those who are new to the channel, welcome. I am Dr. Anshuman Pancholi. I'm a general surgeon and I've been teaching surgery to students since quite some time now. If you want to learn surgery from me, learn surgery in an integrated and conceptual manner and clear your FMG in your first attempt, reach out to me via surgeryforfmge@gmail.com and also subscribe to this channel. So the topic for today's discussion is a concept that has revolutionized perioperative care worldwide, and the topic is enhanced recovery after surgery. Now, ERAS is such an important topic that it is not only used across almost all the surgical domains now, it has also made its way through our examination. So you need to know the entire concept about the ERAS protocols. Now, the thing that you should know at first is that initially it was used for colon surgery. Who was the founder of the ERAS protocols? It was Professor Henrik Kellet from Denmark. So sometimes they ask you the name as well. So basically, what is ERAS? ERAS is a multimodal or a multidisciplinary approach which is done, or the protocols are followed along the perioperative phase. That means pre-operatively, intra-operatively and post-operatively. इन तीनों phases में इसके principles को use किया जाता है. What is the basic means? What is the basic reason for using these principles? It is meant for enhancing the functional recovery of the patient and to improve the patient outcome. तो हमने नोटिस किया था कि कुछ कारण ऐसे थे जिनकी वजह से patient recovery ढंग से नहीं होती थी, and therefore we came upon with these principles of ERAS, which has now changed the entire scenario of the recovery of the patient. Next thing that we need to know is that what is the most important reason why it is used is that it reduces the hospital stay of the patient. The length of the hospital stay has gone down by 30 to 50%, and this is the most important fact that is frequently asked in the examination. Okay, now let's start with the principles first. The pre-operative phase principles क्या क्या होते हैं हम थोड़ा डिटेल में पढ़ने की कोशिश करते हैं ताकि आपको याद रहे, रटना ना पड़े. Okay, all right. So the first thing is that you need to educate the patient and set the right expectations for surgery. What do we mean by that? You need to tell the patient how long is the surgery going to be, what are the expected complications that can happen because of the surgery. देखिए ये बहुत ज़रूरी होता है patient को समझाना. Why? Because if you don't tell the patient the anticipated complications, what will happen is they'll have some pseudo expectations that everything is going to be fine, but if a minor complication also happens, then you are at danger and the patient also loses faith into the process. So you need to set the right expectation which reduces the patient anxiety. That's the first part. Second, smoking and alcohol cessation, extremely important point. Whenever it is stopped, the best is to stop smoking before 1 month of surgery and alcohol roughly 6 to 8 weeks prior to surgery. It is extremely important. Why? Because smoking reduces the mucociliary clearance. So agar smoking continue rahi end tak before surgery, it will lead to what? The chances of pulmonary complications will go up. So you need to stop the patient from smoking as well as from taking alcohol prior to surgery. Next thing is prehabilitation with diet and exercise. What do we mean by that? Suppose the patient is overweight, you ask the patient to reduce the weight prior to surgery, and you also ask the patient to start doing respiratory or pulmonary exercises. Like आपने देखा है कि हम पेशेंट को स्पायरोमीटर देते हैं. आपने देखा होगा 3 बॉल होती हैं उसमें स्पायरोमीटर में. You ask the patient to exercise with a spirometer. Why? Because we are trying to improve the pulmonary reserve of the patient, which helps in recovery after surgery. So prehabilitation with diet and exercise is a very, very important point. Next thing is reduced pre-operative fasting. This is one of the most important points that you need to remember. Earlier, we used to say that a minimum of 6 to 8 hours of fasting before major surgeries was very, very important. But nowadays, we do not follow this principle. Clear liquids are given even 2 hours before the surgery. तो हम fasting recommendations पढ़ेंगे at the end of this video, but this is very important for you to understand that pre-operative fasting has been reduced. Why? Because it is to add to surgical stress later. We'll read that why it was reduced. Next thing is fluid and carbohydrate loading. This is just an extension of reduction of the pre-operative fasting. So we give carbohydrate-rich fluids about 2 hours prior to the surgery. Why do we do that? We'll discuss it by the end of this video. Next principle is giving antimicrobial and and venous thromboembolism prophylaxis. Antibiotics देते हैं बेटा just before, prior to 30 minutes prior to the incision we give antibiotics. We also recommend going for venous thromboembolism prophylaxis in the form of both the low molecular weight heparins as well as for pneumatic compression devices. ठीक है. And lastly we also prefer not doing any selective or bowel preparation. देखो बेटा क्या होता है कि earlier or even up till very recently we used to prefer giving what bowel preparation. हम laxatives देते थे जब भी major colon surgeries होती थी. We used to prefer giving laxatives or enemas. What was found was that it leads to increased dehydration in this patient because the patient used to pass a lot of motions. अब ये समझ में आया है हमें via these protocols and this evidence-based medicine that it is not necessary in every surgery. Only major left colon surgeries are the ones where you require bowel preparation. Otherwise, you can proceed without bowel preparation as well. So these were the pre-operative principles. Let's next talk about the intra-operative. हम क्या क्या करने की कोशिश करते हैं. Number one, we prefer nowadays doing minimally invasive surgeries over open surgeries. So minimally invasive surgeries have pretty much replaced the entire scenario of surgery. We hardly go for open surgery nowadays. Next thing, we prefer local or regional anesthesias, that too which are shorter acting. For lap surgeries, we basically prefer epidural anesthesias. Why do we do that? Short acting kyun? So that the patient emerges from anesthesia earlier and is able to mobilize earlier, as well as to take the feeds earlier, which helps in reducing the post-op morbidity and also the length of hospital stay, right? Next thing is multimodal pain relief. जितने भी तरह से हम pain relief कर सकते हैं, mainly via epidural analgesia. ये intra-operative phase की बात हो रही है, post-operative बात नहीं हो रही है. So multimodal forms of pain relief are used so that the patient morbidity after the surgery also reduces. Next thing is GDFT or goal directed fluid therapy. So we understand the concept now that we don't need to overload the patient. Why? Because it leads to tissue edema, it leads to patient morbidity. Neither do we need to under resuscitate. Why? Under resuscitate करोगे तो क्या होगा? Organ perfusion कम हो जाएगा. So both these things have to be prevented. Goal directed fluid therapy is what is needed, and that is what is followed intraoperatively. Next thing, we avoid putting in drains, tubes and lines. Unnecessary drains नहीं डालना है, tubes नहीं डालने हैं, lines नहीं डालनी है. This is the most important aspect which is taken up now. So we have the entire guidelines. We'll be discussing it as a separate topic कि कहाँ कहाँ drain डालना चाहिए, कहाँ drain नहीं डालना चाहिए, और अगर डाल भी रहे हैं तो जल्दी से निकालना होता है. उसके guidelines change हो चुकी हैं. We'll be discussing that in detail. Next thing is you need to maintain normothermia, body warmers, warm IV fluids, whatever means are used to maintain a normothermic environment. That is what is followed. Why? We have read from our trauma principles that as soon as hypothermia comes in, all the havoc wrecks loose. ठीक है, आपके इन्फेक्शन के चांसेस बढ़ जाएंगे, पेशेंट की रिकवरी अफेक्ट होगी. सो ऑल ऑफ दीज आर इंपॉर्टेंट. देयरफॉर नॉर्मोथर्मिया इज मेंटेन्ड ड्यूरिंग द सर्जरी. कमिंग ऑन टू द पोस्ट ऑपरेटिव फेज एंड द प्रिंसिपल्स दैट आर फॉलोड आफ्टर सर्जरी. क्या क्या होता है? नंबर वन, you need to continue with the GDFT, very important. Number two, we need to prevent PONV. क्या होता है PONV बेटा? Post operative nausea and vomiting. Nausea and vomiting अगर होता रहेगा तो पेशेंट ओरल फीड्स नहीं ले पाएगा, तो रिकवरी अफेक्ट होगी. So therefore we need to give drugs to prevent nausea and vomiting. That is also done in the intraoperative phase. याद रखना, दोनों जगह होता है PONV का. Next thing is early feeding. As soon as possible, we need to shift the patient from IV fluids towards oral feeding. Specifically, oral and enteral is always preferred over parenteral feeding. याद रखना. Why? Because it is more physiological, right? Next thing, avoid early removal of drains and urinary catheters as well. So दोनों NG tubes आपने जहां डाली हैं, nasogastric tubes वो आपको जल्दी निकालनी है, and even urinary catheter so that the patient starts mobilizing. NG tubes हटाओगे तो फीड जल्दी कर पाएगा. Okay. Next thing, early mobilization and physiotherapy. जितना जल्दी होता है, nowadays within 24 hours we ask the patient to mobilize. Don't remain on the bed. Why? हमें पता है कि major surgeries के बाद the patient remains bedbound for a long time. That leads to the collapse of the basal alveoli. Basal atelectasis होता है, and that adds to the morbidity of the patient. Pulmonary complications होते हैं. Therefore, we expect the patient, we ask the patient to mobilize as early as possible, as well as chest physiotherapy is started. Next thing is we reduce the post-operative stress in the patients who are at high cardiovascular risk by giving beta blockers after general anesthesia so that the heart rate remains controlled, and obviously it is more beneficial in high-risk cardiac patients. Next thing is pain relief. Nowadays, a lot of focus is on pain relief. we give what is called as patient controlled analgesia, PCA. ये concept बहुत important है. You should be knowing about patient controlled analgesia. Patient tells you how much analgesia or how much pain control is needed. एक set protocol की तरह नहीं होता है. Patient controls how much analgesia is needed. Next thing is early removal of urinary catheters. We have already discussed that. And defined discharge criteria. ये बहुत important है बेटा. Even before you start thinking or the patient comes into the loop of this operative phase, the discharge criteria gets defined. The patient knows what is the discharge criteria. The entire team which is involved in taking care of the patient knows about the discharge criteria. So the discharge planning starts prior to the patient admission, and you need the support from stoma care nurses and physiotherapists. तो ये stoma care nurses का concept India में नहीं है, but outside everywhere you have stoma care nurses taking care of those patients जहां पे कि हम स्टोमा बनाते हैं. ठीक है, ऑल राइट. नेक्स्ट थिंग इज द फास्टिंग रिकमेंडेशन. इस पे बहुत सारे क्वेश्चन आते हैं, स्पेसिफिकली आपके एनेस्थीसिया में आपने इसको पढ़ा होगा. लेट्स रिवाइज इट हियर अगेन. सो बिफोर दैट वी नीड टू अंडरस्टैंड कि ये फास्टिंग रिकमेंडेशंस बेटा ये एएसए गाइडलाइंस हैं, तो आपको याद रखना बहुत जरूरी है. नंबर 1, क्लियर फ्लूइड्स कब तक आप दे सकते हो? 2 आवर्स प्रायर टू सर्जरी. अभी क्लियर लिक्विड्स में क्या क्या आते हैं पढ़ेंगे अभी. ब्रेस्ट मिल्क यू कैन गिव 4 आवर्स प्रायर टू द सर्जरी. देन 3 थिंग्स, इन्फेंट फॉर्मूला, non-human milk and light meals can be given 6 hours prior to the surgery. ये तीनों चीजें 6 hours हैं, तो आपको याद रखनी है. एंड लास्टली सबसे पहले खत्म कर देना, मतलब कौन सा सबसे पहले देना चाहिए, नहीं देना चाहिए. 8 घंटे पहले हम देते हैं फ्राइड फूड्स, फैटी फूड्स एंड मीट. ये सब 8 घंटे पहले देना है, उसके बाद नहीं देना है. कोशिश करना है लाइट मील्स पे रहो, आप फ्राइड फूड ये सब ना खाएं सर्जरी से पहले. अगर खाते भी हैं तो 8 आवर्स प्रायर टू सर्जरी. नेक्स्ट थिंग दैट यू नीड टू नो इज व्हाट डू वी मीन बाय क्लियर फ्लूइड. ये भी बड़ा पता होना बहुत जरूरी है. क्लियर फ्लूइड्स होते क्या क्या है? सो वाटर, फ्रूट जूसेस विदाउट पल्प. पल्प नहीं है, क्लियर फ्रूट जूसेस हैं. दैट इज व्हाट इज इंपॉर्टेंट. Carbonated beverages, clear tea and black coffee, all of these are considered as clear fluids. Okay. अब now let us talk about the concept of carbohydrate loading, जो हमने शुरू में पढ़ा था. कहाँ पे? प्री ऑफ फेज में हमने पढ़ा था कि कार्बो लोडिंग करते हैं कब? कार्बोहाइड्रेट लोडिंग 2 hours prior to the surgery. 2 to 3 hours prior to the surgery we give carbohydrate rich fluids. That too क्या मतलब होता है हमारा? In clear liquid we give add about 45 grams of carbohydrates. क्यों करते हैं बेटा? पोस्ट ऑपरेटिव फेज में पेशेंट कम्स इनटू अ सर्जिकल स्ट्रेस जहां पे कि इंसुलिन रेजिस्टेंस के चांसेस होते हैं. सो दिस कार्बोहाइड्रेट लोडिंग हैज बीन शोन टू रिड्यूस दिस इंसुलिन रेजिस्टेंस इन द पोस्ट ऑपरेटिव फेज एंड इट काउंटर्स द कैटाबॉलिक इफेक्ट ऑफ सर्जरी. तो सर्जिकल स्ट्रेस कम होता है एंड इंसुलिन रेजिस्टेंस इज ऑल्सो रिड्यूस्ड. दिस इज व्हाट इज द इंपॉर्टेंस ऑफ गिविंग कार्बोहाइड्रेट रिच फ्लूइड्स 2 hours prior to the surgery. So this is what was the theory part that you needed to know. Let's solve a question ताकि आपने जो भी पढ़ा है वो सब हम अप्लाई कर पाए. Okay. Which among the following statements is incorrect regarding enhanced recovery after surgery protocol? They help in reducing the hospital stay significantly. Absolutely true statement. Prolonged fasting is necessary for better outcome in complex surgery. Not true. हमने क्या पढ़ा था? प्रोलॉन्ग फास्टिंग नहीं चाहिए. प्री ऑपरेटिव फास्टिंग को हम रिड्यूस कर चुके हैं. पेशेंट कंट्रोल्ड एनाल्जेसिया इज प्रमोटेड फॉर एडिक्वेट पेन कंट्रोल. ट्रू स्टेटमेंट. बीटा ब्लॉकर्स कैन बी गिवन आफ्टर मेजर सर्जरीज परफॉर्म्ड अंडर जीए टू इंप्रूव पोस्ट ऑप रिकवरी इन हाई कार्डियक रिस्क पेशेंट. एब्सोल्युटली ट्रू. ये देते हैं हम ताकि हार्ट रेट को हम कम रख सकें. राइट. सो द आंसर फॉर दिस क्वेश्चन इज ऑप्शन नंबर बी. सो दिस वर अबाउट द basic pointers that you needed to know about ERAS protocols. Now before I wrap up, I do want to give a shout out to all the 3rd year, 4th year and 5th year medical students, but don't waste your time. Start early so that you don't end up regretting later. FMGE एक attempt में ही clear किया जाना चाहिए. वो तभी हो सकता है when you start early. Subscribe to the channel for more such learning videos and reach out to me for learning surgery in an integrated manner via surgeryforfmge@gmail.com. Thank you so much. God bless you.